Okay, good evening and welcome back to the conceptual basis of urology course. And this is the third one of this year. And today we will be talking about endoscopic combined intrarenal surgery. And there is no better person than Dr. Madhu Agrawal, who is going to talk about this exciting, not a new, but an innovative technique of endourology, which takes care of majority of your upper tract stones, howsoever complex they may be. Before I invite Dr. Agrawal to talk about this exciting thing, you all know Dr. Agrawal is a very well-known figure in endourology. He has been our leader and chair of the SARC group, and he represents the SARC members all around the world and have given opportunity. And really, the SARC urology has progressed tremendously in the last few years since Dr. Agrawal has taken over. I would just, before we start with the presentation, let me just give you a little background before we'll start with the presentation. We need to focus and points to consider, and from Dr. Agrawal's presentation, and also subsequently from the discussion and the question and answer session about the preoperative planning and the ideal imaging for before ECIRS. What about the operating time? Is it longer than the regular PCNL, or is it shorter? Or what about hospital stay? Does it increases if you only do a PNL versus you do a ECIRS? What is the ancillary procedure rate? Should the access sheet be routinely used during ECIRS? We know that it's very frequently used for complex upper tract stones when you're doing RIRS. So with this background, I'll stop here, and Dr. Agrawal's presentation. I'm really very, very grateful to Madhuji for his presence. He is not in his regular city, and he's in a remote area in the northern areas of India. And there are issues with his internet as well, but I think his commitment is really laudable. So thank you very much, Dr. Agrawal, and I'll stop share and we'll share your presentation. Sharif, can you load Dr. Agrawal's presentation, please? Thank you.
Friends, I bring you greetings from the city of Taj Mahal, and it is my privilege to participate in this prestigious program from Aga Khan University. And I'm especially thankful to Professor Hamad for this invitation. The subject which I have been asked to speak upon today is ECIRS, or endoscopic combined intrarenal surgery, one of the most happening hot topics in endourology today. This is my disclosure slide. I have no potential conflicts of interest to disclose. Now, we all know that urolithiasis is one of the commonest problems in the day-to-day practice of endourologists in Asia, and especially our countries in South Asia. And it has a very high incidence in many parts of our countries. Here is a list of the contemporary management options for stone disease, listed in order of their invasiveness. And the new kid on the block in this is ECIRS, which is essentially a combined approach, retrograde as well as antegrade, to the entire pelvic ileal system. Now, it is interesting to look at the evolution of the ECIRS. We all know that PCNL originally started in prone position, and the landmark year is 1976. For many years, prone position has been the standard approach. However, it is interesting to note that supine position was proposed by Valdivia within a decade of origin of PCNL. However, it did not become popular until the modification in Valdivia position, the Galdeco and the Barts, came in about 20 years later, which opened the way to this new approach, which is ECIRS. So this is the original, one of the original publications from Valdivia, where he demonstrated the benefits of supine approach over PCNL, prone PCNL. And in Valdivia's original approach, the patient was supine with a support under the flank with an elevation of about 30 degrees, which allowed access in supine position through the lateral side. However, as I said, it was this landmark publication from Professor Scafone and his wife Cecilia from Italy, which opened the way to ECIRS by using the modification in Valdivia position, what has been called the Galdeco modified supine position, or GMSV. So here the patient is put in a lithotomy or a modified lithotomy position, allowing access to the kidney in supine position for percutaneous approach, as well as a retrograde access in the standard, like in the standard lithotomy position. So here there is lateralization of the Valdivia supine position and a modified lithotomy where the contralateral leg is flexed, the ipsilateral leg is partially flexed, and the flank is raised to 25 or 30 degrees. And as you can see, this allows good access from below as well as from above to allow two surgeons to work simultaneously. Of course, you require two sets of everything here, including the cameras, endoscopes, and maybe even lasers, if you want two people to work together. There is also an option where one surgeon can toggle between two places, going from below and then coming from above, but that would be a little cumbersome, I presume. It is also important to understand that when you are doing ECIRS, you have a rather busy operation theater with two sets of surgeons, assistants, operating trolleys, in addition to the C-arm, the ultrasound, and the monitors of both endoscopes standing across the surgeon. This is the simplified view of the same thing. You can see surgeon 1 and surgeon 2 with two displays and the accessories. Now, when we are using the percutaneous approach to the kidney, we must understand that this allows the best efficiency in terms of stone-free rates, but it also carries a relatively higher morbidity. And over the years, we have been trying to reduce this morbidity by, first of all, finding the best way of accessing the pelvic ileal system without causing injury to the vasculature. And studies from Sampio at the turn of century showed us that this can be achieved by making a direct puncture to the papilla, to the calyx, and not to the infundibulum, because this is how you can avoid injuring the intrarenal vessels. And if one can keep in mind the avascular plane of the kidney, which is between the vascular territories of the anterior and posterior division of the renal artery, then one can access the posterior calyx directly without causing any injury. Now, access to the pelvic calyceal system from above in ECIRS can be fluoroscopy guided or ultrasound guided. The access from below, of course, is straightforward. And for fluoroscopy guided access, our friend Guido Augusti has described it very nicely, that instead of turning the C-arm image intensifier 30 degrees towards the surgeon, you turn it cephalad or caudad, and by removing the parallax between the needle and the pelvic calyceal system, one can easily make the right puncture without difficulty. So, first of all, you access the needle, move the needle towards the calyx, as you see in the first picture, and then you turn the C-arm cephalad, and if the needle is seen below the papilla, that means the puncture is too anterior. And if you see it above the papilla, that means the puncture is too posterior, and then you make the necessary correction. However, in our experience, in addition to fluoroscopy, what helps best, especially in supine position, is the ultrasound guided access. Now, to make the ultrasound guided access, one requires both fluoroscopic as well as ultrasound guided help. The benefits of ultrasound guidance are that it allows better assessment of the depth and plane by providing the third dimension, and easy identification of the dilated calyx. And if there is inadequate dilatation, one can use a retrograde injection of saline through the ureteric catheter to fill up. And of course, ultrasound guidance reduces the radiation exposure to the patient as well as to the surgeon. If you have a puncture guide, that is very, very beneficial, although freehand puncture can also be made with ultrasound guidance. And another additional help is the specially designed eco-tip needles, which have serrations, which show up beautifully on ultrasound. So you can access the lower tract using rigid or flexible ureteroscope, and you can make the percutaneous access with ultrasound guidance, as you can see in this picture on the left. And once the needle is in place, you can draw water by irrigating from below. And as you can see in this picture, the ultrasound allows you to watch the progress of the needle, making the puncture accurate with minimum radiation exposure. And by retrograde saline injection, you can also achieve good dilatation even in patients who did not have too much pelvic calyceal dilatation. And if you keep watching this tip of the needle which because of being an eco-tip needle shows up very well on ultrasound. You can even see the guide wire passing down into the pelvic ileal system. The puncture can be made, as I said, with puncture guide very accurately, but even a freehand puncture can be learned under ultrasound guidance. And you can, like the picture on the left, see the needle passing in. In undilated pelvic ileal system, you can still make puncture with ultrasound guidance because you can see the shaft of the needle passing through the renal parenchyma most of the time, and you can confirm this puncture on fluoroscopy afterwards. So we published this some years ago, how ultrasound guided punctures help percutaneous access by reducing the operating time, radiation exposure, and improving accuracy. And since then, there have been many publications in the world, in international literature, confirming the benefits of ultrasound guided puncture as opposed to fluoroscopic guided. However, I must emphasize that one requires the fluoroscope, the C-arm image intensifier, in addition to ultrasound most of the time. Although there are some of our friends, especially from China, who do purely ultrasound guided procedure. The entire procedure is done with ultrasound guidance and fluoro is not used at all. Now, going further, with the conventional fluoro or ultrasound guided renal access, one does not see the running vessels in the renal parenchyma. With wide band color Doppler, one can see these vessels and one can try to avoid injury to the vessels, the vascular structures during the puncture. So if you make the puncture without the color Doppler, it could go into the papilla, but through the vasculature. And if you use the Doppler, you can make the puncture into the papilla in the least vascular way. And on top of that, if you can put a retrograde ureteroscope and observe the process of puncture and dilatation, it will be the perfect way of making a safe percutaneous access. One additional armamentarium which has helped reducing the morbidity of PCNL is the use of miniaturized instruments. And the same can be used for ECIRS. We have understood very well from multiple studies, including the CROW's global data, that the tract size has direct bearing on the amount of injury and bleeding in PCNL. So by reducing the tract size and using mini and ultra mini percutaneous approach, one can keep the morbidity really low. And this is more or less our standard of care nowadays. A mini ECIRS using a 15 or 16 French implant sheath. And you can use this for large impacted upper ureteric stones. You can use it for multiple renal stones. You can use it for patients who have renal as well as ureteric stones. And here is a case where the percutaneous access, the wire has been passed under endoscopic guidance. You can see that with the ureteroscope, you are watching the tract dilatation, passage of the nephroscope sheath, and the stone fragmentation. So, and then this is the percutaneous view. You can see the ureteroscope from above. and you can fragment the stone with mini PCNL and get all the fragments out, achieving complete clearance very quickly and very efficiently. And you can even see passage of the double J stent endoscopically, so keeping the radiation exposure to the minimum. This is another case with the flexible ureteroscope going up to the kidney and multiple calycial stones, which you will see are being brought down from the calyces into the pelvis to be retrieved by the nephroscope. So the flexible ureteroscope is passed under vision into the calyxes containing stone. On the left, you see the flexi view, and on the right, you see the nephroscope view. And the stone is brought down into the pelvis, what is called passing the ball, and is retrieved through the nephroscope, either intact or, if it's a large stone, after fragmentation. And this keeps the number of tracks to the minimum, the bleeding to the minimum, and radiation exposure also is significantly reduced, and helps in achieving complete stone clearance in one procedure, single procedure. At the end, you have just a small 3 to 4 millimeter incision. The procedure is tubeless in the vast majority of cases, almost always just a double J stent. And at the end, just a small band-aid. And most of these patients go home the next day. The benefits of mini ECIRS are many. The patient position is supine, comfortable. Anesthetist has easy access to the airway. There is visual control of puncture and the tract dilatation. There is less need of multiple percutaneous tracts. Being supine, the dependent drainage helps in retrieval of stone fragments, and it's better ergonomics for the surgeon. And you have, of course, simultaneous access to the ureter in all parts of pelvic calyceal system. In addition, a major advantage is that the intrarenal pressure is kept low as opposed to the standard RARS, and the risk of urosepsis is minimal. There are a few limitations of mini ECIRS, that in supine position, kidney is a little more mobile, the percutaneous tract is a little longer, so renal puncture and tract dilatation and localization of the calyx under fluoroscopy requires a little bit of experience. There is a little restriction in the working surface area, and sometimes superior calyceal puncture can be challenging, although it is not difficult and can be done, and multi-tract PCNL can also be done in supine position. And sometimes the pelvic calyceal system remaining collapsed can interfere with good visualization. But all these limitations are only minor, and with experience one learns how to overcome these. So this is our recent publication on ECIRS in large impacted upper ureteric stone. It is just under publication. There are multiple publications. This is another publication showing benefit of ECIRS for simultaneous renal and ureteric stone access, and the results attest to the safety and efficacy of this procedure. Another study comparing ECIRS with mini PCNL, demonstrating benefits of ECIRS over mini PCN alone, especially in complex nephrolithiasis. To summarize, mini ECIRS allows most of the patients to go home on an ambulatory or a daycare basis, less than 24 hours hospital stay. Because of low intrarenal pressure, the infection episodes are low, the stone-free rates are high, number of tracts is low, and the need for secondary procedures is minimized. And thus overall, this procedure, I believe, has great future. And I'm sure that in given time, more and more people are going to take to it. Thank you very much. I bring you greetings once again from the city of Taj Mahal. Thank you very much.
Thank you very much, Dr. Agrawal. It was a wonderful talk. You have covered most areas very eloquently. If there are any questions to Dr. Agrawal or any comments, please either raise your hand or post them on the chat box. I see among audience, Madhuji, our friend from Kathmandu, Prem Gayawali. And Prem, welcome. Do you have any comments or any questions to Dr. Agrawal?
Dr. Ahmad, I'm sorry that I joined late. Just I was near to conclusion of the Dr. Agrawal presentation. I know he's a great surgeon and he has many publications in PCNL. Definitely nowadays ECIRS is getting popularity. It is less invasive, more clearance of the stone than any one method. Actually, I want to congratulate Dr. Agrawal and also the participants, your junior doctors, who I think they have learned a lot from this lecture.
Thank
Hi,
you,
Dr. Agrawal.
Thank you, Dr. Prem.
Thank you, Prem, for joining. It's a pleasure.
I have a few very basic questions for our audience, and I would really appreciate comments from our experts in the panel. And if there is anyone else in the audience who would like to. So, Sharif, can you share the poll? So the first question is that the ideal imaging in the preoperative planning before ECIRS is CT urogram, CT abdomen with contrast, CT KUB, ultrasound with plain X-ray KUB, or intravenous urogram. So post your comment answers now. Our poll will remain open for another 30 seconds. Okay. About 60% of our participants have voted. And I think we can stop end our poll now. Okay, so that's an interesting results neck to neck between CT urogram and non-contrast CT or CT KUB. Some have also, actually one person has also voted for intravenous urogram. So Dr. Agrawal, what's your practice for routine cases? Would you do a CT urogram in all cases? Would you go for a non-contrast CT only?
See, a lot of people and some of my friends consider CT urogram as the best modality and recommend CT urogram in all cases. However, there are two practical limitations of CT urogram. One is that it is relatively expensive, almost double the cost in our countries. And the second thing is the amount of radiation exposure in a CT urogram is almost 3 times. And you can only use it in patients who don't have uremia. The creatinine is normal because you have to give intravenous contrast. So we have a practice of using a CT KUB with the what the radiologists called MIP reconstruction in majority of cases, and a reserve CT urogram for the complex cases.
Right.
Non-contrast CT with reconstruction often gives adequate information in our experience.
Yeah, I think really if you have a good quality CT scan with nice fine cuts and reconstructed coronal images, provide you the anatomy of the whole ureter. Additionally, in ECIRS compared to PCNL alone, you would also be doing either a retrograde urography or you would be doing an endoscopy, ureteroscopy. So you can appreciate the anatomy of the whole ureter, and if there is any missed stone or something can be picked up, or a stricture can be picked up on your ureteroscopy. So often CT, plain CT would do the trick. Any comments about IVU? Do you still do IVU? Do you see IVUs being done?
Some of our colleagues are still getting IVUs done. So sometimes the patient comes to us with an IVU, and then we will just continue on the basis of the IVU and not ask for another CT unless it is clearly indicated. So yes, a small percentage of patients are still getting IVUs done, but the shift is visible. Most people have shifted to CT. And the primary benefit of CT, the primary benefit of CT is that you get axial images and you get the 3-dimensional picture of anterior and posterior calyces and the structures around the kidney, which information is missing in intravenous urogram.
True.
And like you said,
experience with IVU, are you still seeing them?
Dr. Ahmad, I would like to tell you the first thing before I forget. Actually, the question was not correct because it was written CT urogram and CT abdomen with contrast. It is almost similar. So examinee or the people who are answering, they may be confused. It is the same. In last almost 10 years, in Nepal, we don't see conventional IVU. Almost all are done the either CT KUB or CT urogram. The thing is that if you have CT urogram exactly before the surgery, before doing the retrograde pyelogram, you can counsel your patient that you may not find the stone if either it is in diverticula or it is intraparenchymal calcification. In such cases, you may not get the stone with retrograde intrarenal surgery, and even with the PCNL for the parking of the trocar. Parking of the implants would be very difficult. So in last many years in Nepal, we don't see the conventional IVU. We see either a CT KUB or we see CT urogram.
Yeah, you're right. I think IVU is becoming really extinct. And I was the other day saw a patient who had an IVU from a remote city in Sindh. And the students and one of the residents have actually never seen an IVU. About CT abdomen with contrast is something that in our country, at least, if you write CT abdomen with contrast, they would not have the ureterogram done properly. So you would not see the whole ureters highlighted by contrast. So that's why CT urogram provides you that intravenous urogram-like picture with obviously the advantages of CT. So let's move to the next question. Sharif, can you share the next question? Yeah, we have seen this one. Okay, the next question is that the lowest incidence of bleeding, post-operative hemoglobin drop, and need for transfusion is observed in which of the following endourological procedure? RIRS, ECIRS with flexible scopes, PCNL or ECIRS with a semi-rigid ureteroscope. So the lowest incidence, and not the highest, the lowest incidence of bleeding. I think this is a, thank you very much. I think we should end the poll now. Over 60% have voted. It was quite straightforward. So obviously, RIRS has a very low incidence of bleeding. Dr. Agrawal, why do you think that the bleeding, first of all, do you think that the bleeding in PCNL versus ECIRS is different? And if there is an advantage, because you mentioned complications in your presentation, and bleeding is less than regular standard PCNL, why do you think that there is a difference between the two?
Primarily, it is because of accuracy of puncture. Because if in the past, whenever we entered the pelvic ileal system, most of the times it was like blind. And the bleeding used to be much more common in the past. But ever since we have understood that making entry through the papilla in... Just a minute. Yeah. So by making entry through the papilla, through the least vascular area of the kidney, without injuring the blood vessels, then the risk of bleeding is minimized. And making a puncture under what is called the endoscopic guided puncture, the accuracy is further improved, and you will avoid making injury into the pelvic ileal, into the renal parenchyma, and find the shortest route to the papilla. So in ECIRS, the bleeding is definitely less than PCNL. And if you are doing a mini ECIRS, the morbidity is certainly lower than a conventional PCNL.
Yeah, thank you. And I think the next question is focusing on a very similar aspect. And we'll take this question, and then we'll take some of the questions that are being posted in our chat box. So can we have the next question, please? So the next question is concerning tract dilatation under endoscopic vision. Do you think it is unnecessary in most situations? Concerning tract dilatation, I think there is some issue with the question. Voids, I think the question is probably there's some points missing. So we'll skip this question and we'll come on to the some of the questions in the. So there is one question by Kamran Bajwa, and he says that how to avoid occasional surprise of complex calyceal anatomy when you do not do a preoperative contrast study.
Yeah, so I think the answer is what you have already said, that in all these cases, a retrograde pyelogram on table is necessary. Whenever it's a routine anyway. So whenever you are putting in a ureteric catheter, you put contrast and observe the pelvic ileal system under fluoroscopy before proceeding. And then if there is any abnormality of the pelvic ileal system, especially things like bifid pelvic ileal system or a malrotated kidney, then you can easily pick it up. Although I would agree that sometimes you end up with a surprise on table, but you can see it before you start your puncture. So it's.
So I think the important thing to remember is that majority of your patients who did not have any significant invasive surgical procedures in the past, they can safely have a non-contrast CT as the investigation. It's in very complex situations where previous open surgeries or multi-track percutaneous surgeries have been performed that you may get surprises when you only do a non-contrast study. So in majority, in my personal practice, about 95% patient would not require any contrast study prior to most of the percutaneous procedures and even ureteroscopy and RIRS. Prem, do you share the same impression, or you have any other observations?
Can you hear me?
Yeah.
Okay. We, as Dr. Agrawal told, actually, I confused his voice with Dr. Mahesh Desai in the beginning. It is exactly similar voice. I agree with him. Always we do the retrograde pyelogram before performing the PCNL. And even the RIRS, we should do the retrograde pyelogram. Then the exact anatomy of the location of the stone, number of the calyces, size of the infundibulum, and possibility of the diverticular stone or the parenchymal calcification can be seen. That's why before procedure, we always do the contrast CT scan.
Okay, I think, right. Thank you very much for your opinion. So let's come back to some of the points that I have raised prior to the presentation about preoperative planning and ideal imaging. And there are some opinions. Non-contrast CT suffice in majority of situation, but in certain special situation, you probably do need a contrast study beforehand.
Dr. Hamad, can I add one thing? There was one question: when will be the more bleeding with the during ECIRS or the RIRS? Actually, sometime in RIRS also you can see the profuse bleeding. In case if the stone is impacted in the PUJ and there is a gross hydronephrosis, during RIRS, when you break the stone or dislodge it, it just starts to bleed like the post-catheterization in chronic bladder outlet obstruction. I had one case, probably I have gone beyond 2,000-3,000 of the RIRS. One case I needed to transfuse the blood and put the three-way catheter. He bled like that because of the sudden collapse of the calyces from the kidney. So it can happen, but it is very rarely.
Yeah, I agree that post-compression hematuria is something that would really be very difficult to manage, because these are capillary bleedings from all over the collecting system. Very rare, but as you've noticed that it is seen in among thousands of cases that you've done in one or two situations. Operating time, is it longer than traditional PCNL? What is your observation, Dr. Agrawal? Is the ECIRS a shorter procedure than a standard PCNL, or it takes longer because you're two procedures going simultaneously?
Well, in the beginning, when you start ECIRS, and I'm saying this because people in our audience who have not been doing and they want to do it the first time, it seems a little cumbersome, especially to organize the OT and position the patient. You definitely take slightly longer time in setting up two sets of endoscopes, the monitors and everything around the operating table, and you need to know exactly where to place what. So with the experience, this time is reduced. Secondly, positioning the patient. Instead of turning the patient prone after cystoscopy, you position the patient only once. So in a way, it saves a little time. But again, in the beginning, positioning the patient for ECIRS takes a little while. But with experience, this time is reduced. As far as the actual operating time is concerned, I think since both the people are working simultaneously, the time is not prolonged at all because of two procedures. On the other hand, since you have access and approach from both the sides, it actually helps expediting the procedure, and you end up faster.
I think a couple of factors. Number one, that if you do lithotomy position, retrograde catheter placement, followed by repositioning patient to prone, and then doing your PCNL, and if you have to do multiple punctures for complex, and remember that ECIRS is not for your day-to-day small renal pelvic stones. It is for most of the time complex stones, which cannot be managed by standard PCNL. So in that situation, the literature also says that the time is shorter with ECIRS, if you compare head-to-head the same type of stones compared to a multi-track PCNL. And as rightly pointed out by Dr. Agrawal, it's whenever you start off a procedure, and if your second surgeon is not really very competent, and you have to go from one to another, then obviously it would add on. So you need to have two surgeons who are relatively well trained in doing an endourological procedure, so they both do a good job. Hospital stays, as already mentioned, is really very short. It is more like RARS rather than like a standard PCNL in which your patient may stay for a few days, whereas majority of your RARS and ECIRS patients can go home within 24 hours. What is the opinion, Dr. Agrawal, about use of ancillary procedures like subsequent procedures, lithotripsy, etc., if you do a ECIRS versus a percutaneous procedure?
I think the biggest benefit of ECIRS is avoiding the need for secondary procedures, because ideally one should have complete stone clearance in one go in almost all cases. And that is our objective whenever we are doing this procedure. So except maybe very complex pelvic calycial staghorn stones or multiple stones where sometimes you require a second look, I think almost everything can be done in a single session in ECIRS, as opposed to an occasional PCNL where you require a second sitting, and many cases of RIRS where you require a second session. In fact, the benefit of percutaneous approach is allowing clearance of the stone fragments and the dust on table, and allowing you to confirm endoscopically as well as fluoroscopically that you have achieved complete clearance. And ECIRS is one step forward on that.
Right. The last point is about the use of access sheath. So if you are doing RIRS, what percentage of procedures would you be using an access sheath compared to ECIRS?
Well, in our practice, we generally do our flexible ureteroscopies with the sheath and choosing the smallest sheath most of the time, which allows the ureteroscope. But if there was a case where the sheath would not go, I would not hesitate in going sheathless. And since we already have the percutaneous access once the puncture is made, then it doesn't matter. The sheath is not required for the purpose of drainage or for the purpose of stone clearance. So as such, in ECIRS, sheath is not really required.
Yeah, that's I think a very important point, that the primary purpose of having a sheath is to decompress the collecting system, because your irrigation is collecting there, very little possibility of clearance, and increasing the intrarenal pressure, chances of bacteremia, etc. Whereas in ECIRS, you have an access sheath, the implant sheath, which continuously drain the kidney. And plus the second advantage of retrieving stones, again, they are retrieved through an implants rather than an access sheath. So that's very important. So I think most of our colleagues who have not yet started ECIRS, it's a wonderful opportunity to listen to Dr. Agrawal's experience, and I'm sure that we will soon be embarking, most of us who have not or not doing it, embark upon this exciting procedure of Spanish origin. Escofón is our friend, is the real pioneer, and I think it's more than nearly 20 years that he has described this, and it has become part of our guidelines. It has become part of our textbooks. So great work to our colleague, Dr. Escofón. And with this, I'm really grateful. Let me see if there is any other question. Yeah, there is no question further. So with this, I really am grateful to Dr. Agrawal for his very kind presence, and I understand it's difficult for him during this time when he is visiting his friends and colleagues, and to all the delegates. Thank you very much, and hope to see you again in the second week of April with another exciting session. And I'm sure our colleagues from India and Nepal will also be able to join in our conceptual base course. So thank you very much, and good evening, and a very good weekend to all of you.
Okay, good night.
Thank you, Prof.
Good night.
Thank you, Dr. Prem. Thank you, Dr. Hamad, for this opportunity. It has really been a pleasure, and it's always great to see you, talk to you, and participate in any academic program with you. Thank you very much.
Take care.
Okay. Thank you. Bye-bye. Good night.
Bye.